All right. Hello and welcome to another Down Fracture podcast, a podcast for talking jaws. Downfracturepodcast at gmail.com. Feel free to email us as always. Did have some email correspondence this week. Again, that was useful, interesting, helpful. So please keep that up. Send us topics, suggestions, cases. We haven't gotten a lot of cases, Sam. I think cases would be nice.
Yeah, I like cases. Those are always fun to talk about. But I feel like we got some good topics going into the future
I
that'll be
do.
good to talk about.
I do kind of feel like our audience is not pulling their weight here a little bit, though.
I mean, we're just getting rolling. So I'm sure our conversation today will prompt some people to weigh in. So
All right, fair enough. So, per usual, this is Dr. Michael Wasson of Arizona Jaw Surgery, joined by Dr. Sam Bobek of Seattle Jaw Surgery. And today, Sam, we're talking about non-unions in orthognathic surgery.
non-unions, yeah, I think it's a big topic to go with all orthognathic surgery. Um, but this is I think this is something where the literature kind of lets you down. And I feel like the numbers are such that it's hard to really get a lot of experience with this. And so I think it's good for us to just talk about ways we manage it. So I like this topic.
For sure. For sure. Did you see much of this in training that you had to do with? Do you recall revising cases due to these things, either from cases that you and your program did or being referred in from the community?
Yeah, I mean, I don't know if I had really a mature thought about this at that time. There was cases where we'd have hardware failure or like a sagittal non-union or a segment in the maxilla that didn't heal, and we would manage it. Um, I think now like the non-union under the umbrella of revision surgery, I feel like splitting non-union off of revision is an important thing, right?
Okay.
So I think revision experience from a patient standpoint, I think includes non-unions, but it's like a whole different mechanism than revision jaw surgery, I think. What
So what
about you? Did
about,
you see that?
yeah, yeah, I mean, I get what you're saying. What would you think about even separating off hardware failure? Do you lump that into like, do you feel like that's part of non-union or do you feel like that's a separate thing? I tend to think it's kind of a separate thing in some instances.
Really? So in what
It would paint
situations
you
do
a
you think?
picture.
Yeah, I'd like to. Yeah, because in my
I'll
mind,
paint.
those are the same.
Yeah, so I think until I had some circumstances, I may have kind of agreed with you, but I had a case not too distant past where I don't want to get into the minutia, but let's just say I was dealing with a lot of soft bone and I didn't know this ahead of time. I got in there in the middle of it and it was, as you were fond of saying, a goat show,
Yeah,
which I'm not even sure what that means, but
it's a ridiculous thing to think about.
it is kind of
Yeah,
ridiculous. We got off topic. All right. So soft bone, I'm trying all sorts of different things. I'm having the bone's so soft, I'm having screw heads go through buccal cortex. I'm just kind of it's a flail. It's like I'm trying to get fixation anywhere, however I can, kind of goat show going on there.
yeah,
So I ended up temporarily feeling like I got fixation, and then over the coming weeks, that kind of failed. And so I would agree that there was a lack of union of bony healing, but I don't know that it was given adequate time to develop. And so I don't know that I fault the bone healing as much as I do the bone quality. So I'd almost say it's hardware and bone failure.
yeah. But I mean, that's kind of the same, right? Like a non-union, it's always hard, or I think it's hard to parse out what the specific problem is in the scenario. Because at this stage of my life, I've seen, I think, at least my fair share of non-unions. Those are my own patients. Those are other people's. It's just over the years, you just they show up in ways. And like what you're describing, like your fixation isn't necessarily the best, is kind of an early failure, right? Like an early union failure, which you can say, it was hardware, but I mean, it could be also how surgery went, right? Like there was a bad split. It could definitely be the quality of bone. As I'm sure you run into patients who just kind of disregard postoperative instructions and they're using their mouth normally. And so when things shift in the early phase afterwards, I just kind of lump all of that into non-union.
Would you
Probably
not
for
even have like a,
simplicity.
yeah, would you not even have a time point cut off? You know, what I mean, I don't even think I would consider something a non-union until I got at least a couple of months out, if not more. And, so when it happens early, I guess I'd separate that in my mind.
Oh, okay. So you're saying like if you lose failure or lose fixation in the first, let's say, stage of healing of the first 6 to 8 weeks.
Yeah, because I mean, I know that you have patients that grab their maxilla and wiggle it to see if it's fixated,
Sure.
and then maybe even being the ones or the thing that causes a non-union. I don't know that I would, if there's still a little mobility at 4, 5, 6, 7, 8, 9, 10 weeks, I don't know that I'd call it non-union at that point.
Yeah.
But
Okay. I think that's fair. I mean, it's a good conceptual breakdown in terms of how to manage it. Because I think the early failure of hardware, I guess so I was kind of grouping into this, but you think that's a separate topic, or you think that that is
I
within
don't
the
know that it's worth
umbrella?
another topic, but I do almost consider it a separate entity. Now, you could argue that the management's kind of the same. Um, but I don't know. I do think it's a different animal, so to speak, because you're going back in and you have to figure out what failed. Because if it's the quality of the bone, that's not an easy fix. Like you can't reverse time.
Yeah.
Um,
Because I
whereas
mean,
if it's non-union and like I think there's mechanisms to fix that, right? Like, because a lot of the factors within that entity alone, you can control. You can, the standard treatment of like curetting and all the things that I'm sure we're going to get into. Like, I think those are two different
sure.
scenarios.
Yeah, and depending on how you manage the early failure, it may ultimately be a non-union.
I mean,
Gotcha. All
yeah,
right,
yeah,
I'm
yeah.
on board with the splitting of the two. Um,
Semantics to an extent. I
yeah, but I
mean,
mean, it's management of fixation or it's management of bone healing post orthognathic surgery. Because this idea that we're going to cut the upper and lower jaw or and then reposition them in a better spot and then get the patient to heal in that spot without trouble is a bit of a complicated thing.
yeah,
And I think I've noticed kind of phases of my career, and I haven't been doing this all that long, but long enough to kind of see it. The conventional wisdom when it comes to management of these things and how they show up clinically, I think are good tips that I'd probably tell myself years ago. Because I don't know, like as you asked about residency, I felt like what I learned in residency was maxillas have a higher rate of non-union. They will eventually heal if you give them enough time. I got that advice where you can even just wait a year sometimes to allow them to heal. And they eventually will. Mandibular non-unions and actually non-unions frequently would be managed with periods of IMF. Is this similar to you? Is that what you got in residency?
yeah. I mean, I'm similar to you in the circumstance that I honestly don't. I feel like my exposure to it in residency was mostly educational and not clinical. Like I don't remember going back in and I could remember a couple of times where patients developed malocclusion or like, it seemed like things were good on the table. We see them at 1 or 2 week post-op and things are off and we go back in and refixate them. I can recall doing that a handful of times, but I don't recall it being attributed to hardware failure or bony healing issues, as you're saying. I remember, I just feel like it was more, we didn't see the condyle kind of thing. We didn't
Yeah.
fixate it appropriately. Maybe they weren't fully in the splint. Maybe the tongue was in between the splint and the teeth kind of thing. Like I don't have much recollection of going back in for non-union malunion, but
Yeah. But I
a
mean,
big part
non-unions,
of it's a big part of a jaw surgery practice, to be
it,
honest.
it,
Like
it,
it's
it
real world
really
stuff.
is. Yeah, I agree with you. Because I mean, nowadays, I mean, I think a reasonable number in terms of how frequently this stuff happens is about 1 in 50. I feel like that's an the literature is broad when it comes to this, but I think 1 or 2% as a patient experience of non-union, because it gets down to, well, what's the sagittal split non-union rate? What's the Lafort non-union rate? You know what I mean? And if you're doing a double jaw and chin, they have 4 spots that could, in theory, have non-union. And so I just think it's a bit of a ballpark, the 2 20 80 rule. I think this is something that's infrequent, but it happens enough. So if you do 100 cases or if you do 200 cases, you might see 2 to 4 cases a year. I think that's a reasonable number. What do you think? Is that low,
Yeah,
high?
when I'm looking back on it, and I'm entering year three of this practice, my newer practice, and I've had I've had two that I can think of, and that situation I was just describing, which I don't attribute to non-union. And I would say with my numbers, that's fairly close. And there may be, I may have some lingering. Like I showed you this photo the other day. Like this is probably one in waiting. Uh, you know, who
Yeah.
knows?
So
If one were to have one, it might be this one, kind of thing.
and I think the online community kind of is aware of these sort of things as well. And I mean, honestly, non-union is a whole nother operation frequently. And so, in terms of consequential complications, that would put this high on the list, right? So, I mean, bone's not healing. And so, I don't know. I think in mandible non-union, I find that to be tricky, and one of the main reasons why I like getting an early cone beam. I think when we had Farrell on, he was a big proponent of getting it the day after surgery. I get it in the first week. I think an early cone beam serves as a point of reference because it can be tricky when people come in, especially at 1 week, but also at 3 and 6, and they have a bite change. Is it numbness and they can't find their bite, or is it the fixation has shifted, right? Because in what you were saying with the early fixation failures, that's generally poor bone. That's generally, aggressive advancement. You have a 2 centimeter Dalpont, and your positional screws are holding on to a little stick of bone on the lingual plate, like that, those sort of situations. And it sure is nice to be able to superimpose an x-ray 4 weeks after surgery if there's a bite change. Because unilateral failure of fixation in SAG is the midline away from the side and an open bite. And a bilateral fixation failure is just an anterior open bite. Like they just
Yeah.
hit on the sevens and they get a class 3 malocclusion. And sometimes you see that after that 6 week period of time. So kind of develops slowly. And it seems like for those people in my world are the people that the orthodontist is calling me back and saying, hey, their teeth fit really well with rubber bands, but as soon as I take the bands off, they have a class 3 open bite.
Mhm.
Like they almost don't need to come in. I know it's going to be a non-union, right?
Yep.
Um,
Have you considered using two screws in addition to your plate to fixate
yeah,
your
I do
mandibles?
lots of crazy. I mean, yeah, 2 screws, single
Would
screws.
be
I
solving
think,
most of your problems here.
yeah. But the problem of fixation failure still come up. I think management of mandibular non-union um, is difficult though. I would say the early fixation failure, if it's because you had difficulty putting fixation on the first time, you're going to have to put a recon plate on
Yeah,
or treat him with closed reduction. So you just
absolutely.
IMF. So
See, that always makes me nervous though, because I would agree with you, and I think that's important for the audience who maybe doesn't have a lot of experience. I think you're right. It's recon plate or it's MMF of some kind. But like that makes me nervous when we're talking about poor bone quality. And maybe I'm overly cautious, but I don't love the idea of someone who has maxillary fixation in poor bone now being an MMF to fix a mandibular problem. Like I think that's taking a mandibular problem and making it a bimaxillary problem. Like I think I would just have concerns out of ripping out your maxillary fixation.
I think it's exactly right to be concerned about causing new troubles in the maxilla when you're dealing with loss of fixation in the mandible. I just they seem like they're different entities. Like it just seems like biting and chewing is more of a lower jaw healing problem. Getting bumped in the face is a lower jaw healing problem. Infection is more of a lower jaw healing problem. And then upper jaw is like bruxism. It's rubber band use. It's, over aggressive movements, those sort of things, right? So I think in the mandible non-union in the past, I've been partial to just putting a recon plate on. Um, do you do you put them in IMF? What do you think?
No, I mean I've been fortunate, and we've talked about this before. Other than that scenario, I was just I shared and keep referencing. I don't recall having it in the mandible. The ones I've had have all been maxilla. And I think my use of two screws in a plate instead of one, like you do, probably has a lot to do with that. And also just, you do some crazy cases that I'm starting to do more and more of. And so I'm sure my time is coming. The clock's ticking on me, but I've
Yeah, because I
almost,
mean, there's harder anatomy, and there's times where um the bone quality isn't the best, like you were referencing. Because I mean, I do think, taking a step back, there's subgroups of humans that are at higher risk for bone healing trouble. Like I think like the severely class 3 Caucasian lady is set up for bone healing trouble. Like round mandible that's short, thin bone everywhere in the maxilla. And in my neck of the woods, they're not getting enough vitamin D, that sort of thing. I think older people, there's just the quality of bone that isn't the best. So some of the MMA patients where the bone may not be the best and maybe not the best at following post-operative instructions perfectly. That, when it comes to that part, by the way, I think it's a little wild that we expect people to not chew at 100% rate. I think, some accidental chews happen, but at the same time, there's people who just straight up like chew gum right after surgery and everything.
yeah. Oh,
It's
yeah.
a different animal. But yeah, I think there's groups of people that seem to have more trouble healing. What do you think?
Yeah, definitely.
Like over
Some of
60,
them,
another one. Did I
what's
say
that?
the over 65 group with jaw surgery?
Yeah. I mean, I would throw out there that in the ones where I've had issues, they're not always predictable. Like, you're mentioning some subgroups and other people, and I've had some young, healthy ones, and it's like, why did this happen? And I think that's difficult. I mean, some of them you can explain, they're big movements, other things. So let me ask you this, like, let's kind of go through this starting from the beginning. What's your discussion preoperatively with these patients? So someone's coming in for orthognathic surgery, consultation, you're doing consent, you're going over things with them. I don't historically spend a lot of time talking about non-union. Do you spend more time with it as you've gotten more seasoned in your practice?
I mean, I bring up the idea that the bone needs to heal. Because these days, what's different in my practice about the mandible, at least, is I'm really removing interferences to give the nerve space, which is, I think, not the best for for bone healing. Like the good things for bone healing can be against the nerve healing. But I definitely bring it up in the maxilla because I think it's one of the significant complications of maxilla. Discoloration of teeth, negative nose change, non-union maxilla, heavy nosebleed. I think those are the big ones. If I was having maxillary surgery, I'd want to know about those. So I think because nowadays I just see maxillary non-unions more frequently. I think I'm more like your experience. My early career, I saw mandibles more. Then kind of mid, it switched over to maxillas, and it's probably still there, which I think is conventional wisdom. So I'm not sure what was going on early.
All
So
right, so then let's okay, so that's consent. Let's go step by step. Then intraoperatively, have you changed anything over your career with more exposure to non-unions? Is there anything you do differently now versus 5, 10, 15, 20, 25, 35 years ago when you started?
intra-op.
Yeah. Or like fixation, techniques, post-op instructions. Like we talked about how you maybe manage some of this with the consent and informed consent process pre-surgery.
Well, yeah, I talk to people
About
about it all the
interesting.
time. I mean, I think there's also like how we're moving things, right? Like in the maxillary non-union discussion, which you haven't really talked too much about here. That's obviously the unstable one, right? Like moving the maxilla down, widening it significantly, changing the pitch of the occlusal plane. All those things are pretty unstable in terms of the maxilla. And if you're combining those, right, like the big MMAs that you're doing, 20-degree counterclockwise, transverse 12, 14 millimeters, it's just an unstable construct. And so those are situations that Botox is discussed, right? Like Botox, custom fixation is out there. And I know that's a triggering topic for you, but it is out there. I think with time, I've come to appreciate the need for grafting, and I've come to appreciate the difference in screw from company to company. So,
Hmm.
like the plates and screws, I had thought for a long time were just plates and screws, like they're the same. But now I think there's some nuance to that. So,
Okay.
have you changed anything?
Yeah. So the things I can change are, some of them you mentioned bone grafting. I'm more, I would say I didn't do a ton of bone grafting with jaw
Agree.
surgery and training. I didn't do it in my
Agree.
early years. I certainly do it more now. I don't recall even, we would take some bone chips that we removed from the maxilla and put them between the segments in segmental maxillary surgery. But now, I kind of do that, or I try to have something rigid in places between the segments, and then I fill in the gaps with putty, bone graft. We didn't bone graft mandible, the mandible either. We weren't worried about the divot.
Yeah, I think we had a very similar residency experience in that way.
I do those things more and more now. I think the other thing I would do that I do now is I fixate the segments. I was trained just, kind of the four L plates and then your splint. And that's all I did for a long time. And now as you can see on the screen for our vast listening audience, I tend to try to find some way to fixate intersegmentally specifically, because sometimes that anterior segment either has no fixation or minimal fixation beyond the splint and the soft tissue tethered to the other segments. And so that always made me a little uneasy. And so I tend to fixate that now, either, with plates like shown here. I usually maybe just do one side, or do your cutesy screw ski, as you call it
So
here. If
nice.
I'm
Little
doing,
two-piece extra
yeah,
screw there. That's so cute.
I just don't do a ton of two pieces.
I
And
agree with you.
but when I do the screw across. I wish I could do a single screw across 3 and 4 piece segments, but angle and orientation and stuff always just makes that near impossible. So I think those are the main thing. Actually, I would add a couple things. I was trained. I don't know what you do or how you were trained, but I was trained to put thinner plates in the anterior maxilla, especially in thin females. You can feel the plates through them through the skin sometimes. And then we would put thicker plates in the posterior. And I
So
pretty
you would
much
do like
now,
1.0s or 1.5?
yeah, like 1.5, 1.6, 1.7s, depending on the company
Yeah.
and what was available at that time, and then 2.0s mostly in the posterior. And I think whatever I can, I put thicker, more rigid plates on. I think it went from that was the norm. I would put thin plates in the anterior on everyone, thick plates in the back, and then I would have some exceptions. And I think now it's flipped to where I put thicker fixation on, bigger fixation on, unless specifically it's a thin, like female who I think might feel them. And then I use thinner plates in the anterior.
I'm um I think generally maxillary fixation is shitty. You think
Yeah,
that's is true, or I mean not always, but it's very cantilevered fixation. You're just fixating high and on the anterior aspect of the bone. And so getting stronger fixation than there, I think is reasonable. I'm open to the idea that really mobilized maxillas have a higher rate of non-union. What do you think about that? Like if you, because I mean, as time's gone on, I'm pretty good about mobilizing maxillas to get them passively to sit in the splint and put them where I want them to put. Because if there is any areas of tension, let's say in a maxilla, that's playing out and changing your condylar position, right? So
absolutely.
I think that isn't entirely solved by custom fixation, by the way.
No.
Custom fixation, it can pull out of that. And custom fixation, I think it is a solution that people use because the pros on that is that you can design your screw hole locations into better bone. You can join the plates into a single construct, so it's better rigidity. Um,
No wear, and you're not weakening the plate by bending it.
yeah, totally.
Mm.
And so, I mean, conceptually, custom hardware seems like it would help this problem of non-union. What do you think?
You feel that's not the case? Like when you see other people's non-unions, do you see it with custom hardware?
I had a very
Anecdotally?
notable case in my life, which you know how it is. You have like a single case and it's just like burned into your memory. It was just prior to the pandemic. It was an inverted L case that I did. He had custom hardware, and I can't remember how many years before 2020 it was, but it was more than a couple. Case was done, and everything else was fine. And he came in the week of the world shutting down with an anterior open bite. and he just never had union. It's just that his custom hardware held the bones together, and it was just a matter of time before the hardware gave up. And so, like the late mandibular non-union or late maxillary non-union, it's not that it's late, it's just that it never healed in the first place. And so, what I'm generally concerned about when it comes to custom fixation is um, that it's just
Is that
delaying
it holds up
the
so
the
well that it
diagnosis.
disguises? You're saying it's almost problematic and that it disguises or hides a lot of the problems?
Yeah, that you don't really know if they're healed, right? Because I mean, getting X-rays to evaluate bony healing in maxillas is kind of notoriously difficult to figure out because they heal like zippers. And so I think, you go clinical movement, right? If they're maintaining their occlusion and it's really not much mobility, then you go with it. And my concern on the more rigid fixation of maxillas is that they're just non-unions waiting. Um, so I don't know. I think there is something to custom hardware helping out those situations. Like if you could anticipate some people that are higher risk, like let's say just downgrafting a maxilla 6-7 millimeters, right? I mean, um, that's a solid utilization of custom hardware. Like what you're showing right now with that custom would have been great to have, which you had
Uh,
custom though.
I did have custom. It didn't end up getting used. Let's just say it that way.
Yes, and that is definitely something that can happen. But I think maxillary non-unions, when it comes to those, I think the thing that I key in nowadays is loss of tooth when they smile. Like, you learn as a resident that the maxilla will eventually heal. I think that's probably true just because the maxilla will just run into something eventually, right? Like the, come up with some case where that isn't true, but um 6 months, 12 months, just loss of incisal show, hitting heavy with their front teeth because as the maxilla loses vertical dimension, mandible rotates forward, right? So, like, if an orthodontist is giving you feedback that they're chasing a class 3 malocclusion for a year after two jaw, the idea should float in your mind that the maxilla isn't healed or is at least still shifting, right? And I think that's a sneaky sensitive measure on how that goes. I just saw someone recently and they had non-union and that's what the trouble was. And so superimposing the data helped kind of figure that out.
Nice.
But I mean, I really do think this stuff comes up, and I think the idea of I'm going to do this thing and I don't have that, or I haven't seen a non-union, so I'm not going to have that trouble, or there's some issue with, patient or surgeon when it comes to this. I think it's complex and, um, it's just something that you're going to have to manage if you do a lot of this. So how do you
Yeah.
manage, we talked about mandible. How do you manage, actually, did we talk about that? How do you manage mandibular non-union? Let's say two,
Well,
3 months, 6 months after proximal segments rotated up,
I
open
mean,
by.
I would say fingers crossed, knock on wood, whatever you want to do. Haven't been exposed to that too much. I
But
mean,
let's say someone comes in this week, next week.
don't you put that evil on me,
I
Sam.
know that just saying it. I'm bringing it into the world.
If
Hypothetically,
I,
let's
what do
that's a
you,
very hypothetical situation. Somebody shows up tomorrow and it's that. What do you think?
so you're saying someone shows up with what clearly looks like either unilateral, bilateral, mandibular non-union, my
Yep.
patient or someone else's. How am I going
Maxilla's
about
healed.
that?
Maxilla's healed.
Yeah, I think I'd go about it and I would just probably try to repeat the surgery, remove the hardware. I guess I would be very inquisitive as to what caused the problem to begin with.
Yeah, now
Was
you're
it
talking
poor
my
bone?
language.
Yeah, was it poor bone quality? Because again, I don't have much control over that. If it is, then I'm probably thinking recon plate. And I'm consenting for all of these things. And because I mean, I think you have to tell the patient, I may get into something when I'm in there that I'm not expecting, or this, I don't know what to expect till I'm in there. So, I mean, I think you're consenting for hardware removal, recon plate. I think you're bone grafting. I mean, I think you're consenting for all that. So I think I would go in, remove hardware if there's any left and still there, if it wasn't previously removed. And then, I mean, that's where I think it's tricky, as you've mentioned, because if you've hollowed out that segment, a lot of times you may not feel like you get much blood supply between your segments there. So I would try to probably do something to get things to bleed a little bit, the classic curettage and maybe even taking a burr or something to try to get something to bleed in the area. And then I would make sure I had good approximation of my segments. Maybe, like, this is going to sound bad, but my first surgery, I'm very nerve conscious. This surgery, I would be less nerve conscious, and I would even entertain the idea of putting putty on the proximal segment and then shoving it against the distal segment and then
Yeah.
fixating.
I mean, what I've been surprised because I've been stressed about nerve and that sort of thing as well in these situations. What I've been surprised with is the nerve just seems to be in scar tissue. Like it just seems to be like it's not a clear nerve as it is in a fresh mandible, right? It's just in like a gray or white plane of scar tissue that's, I just because you obviously need soft tissue out of the bony segments if the bones are going to heal. And it's very kind of like, I don't want to remove too much of this, like I think in mandible non-union, I'll be interested to hear what any of our listeners, if they're still listening, weigh in on this one. But I generally freshen up the bony margins and really try to mobilize the two segments again. But getting to like solve the problem differently, I think is good. Nowadays I'm printing out a 3D model or getting custom hardware printed ahead of time. I think I would do that on a revision in the mandible,
You
or I'm
get
sorry,
custom
a
hardware on
non-union,
mandible. What do you mean you get custom hardware on the
like a
mandible?
custom plate to do a non-union repair in the mandible. I think is reasonable. In practice, I'm just printing out a 3D model and
How are you? I mean, how are you
ending
doing
a
that with
plate.
having to seat the condylar segment? Like, I mean, are you just presuming everything's in
Kind
the?
of,
I mean, everything's already in the right place, and you're just printing a.
because in the situation of non-union, you have the post-operative data, right?
Yeah.
This is obviously dependent on how else everything has healed. But if the mandibular position at 1 week was fine, then there's nothing holding you back from just printing that model, right? And then you have the recon plate for it.
So you're saying take your 1, 2, 3, 4 week post-op if you have access
Yeah,
to that before there was a problem, print that off, pre-bend the plate to it essentially,
yeah.
or okay.
Or you could sterilize it and bend during the OR, but pre-bending it and having it set up.
Yeah, no, that
Because
makes more sense.
I think like cutting guides and drilling guides I think are a bit much, but the general thing with recon plates that I found is hard is if there's a chin involved, and if you've already made a long Delpont, you really don't have much real estate in the distal segment. Like there just isn't. And so that's probably the threshold where I would lean towards more of a custom plate, just because you can steer it in different directions, right? Like you can have it go up on the chin. But I don't know that and grafts. I think bone grafts is key. I think getting some cells in there to help you out with healing. So I got a pretty low threshold these days about putting some hip in there. What are you doing?
Really,
Little
I don't think I'd put hip in there.
aspirate, bone marrow aspirate,
I don't know that I do any of that. Uh,
bone BMP.
I would consider BMP.
Okay.
Um, I would definitely consider BMP. Again, I would consider if I felt like there was, if I thought that either the problem was there wasn't good intersegment contact, I would try to correct that. Maybe as I said before, I haven't done this but like one time, and it was just for jaw surgery, wasn't revision um or for a non-union. But I would slap some putty on the inside of the proximal segment, and then I
To
would
graft the defect so you can get some bone
I'd
bridging.
kind of shove it together to try to get as much length of bony contact, hopefully. I haven't seen that patient more than just a few weeks out to know that that worked. I have some reservations about that as well. But, if you're doing asymmetry or a big advancement and your contact is really just at the anterior aspect of your proximal segment and there's separation a lot of the distance, like helps me sleep a little better at night putting something in there. Um,
Yeah. Yeah, no, I think grafting's great. I think looking at it with some fresh eyes is always hard, I think, because it's you want to not have non-unions, but you also want to do the right thing. And so it's like I don't want to undertreat or overtreat. And so trying to look at the whole problem with fresh eyes, I find to be
yeah, the
a challenge with this
Well,
pathway.
let me get your thoughts on this because I guess I didn't finish my answer to your question of what do I do differently. I would say I drastically, and I mean significantly, have decreased my use of elastics. I
Sure.
feel like that can and is a problem at times. I almost, if I do a bilateral TMJ replacement and I take the coronoids, I put them in elastics for sure. Otherwise, I don't put a lot of people in elastics anymore. Um,
Yeah, because I mean, elastics, in my mind, it's more of a maxillary healing trouble because it's
Me
the
too. I
thing I tell
agree.
patients, it's like going to the gym and you have one of those stretching bands that you're like doing resistance exercises for your shoulder rehab. You're pulling on this rubber band and it's, it's pulling back. And as you talk with rubber bands on, it's pulling on the upper jaw. And a little micro motion is a lot. And so, I've been definitely trending away from using more rubber bands. Like band IMF, I think it's different than I'm using bands to get their teeth to fit a little bit better, to take advantage of the wrap phenomenon, to kind of get a premolar deceit, those sort of things. Cause you just got to be careful with that. Cause if they're sitting there talking to their friends and going back to work, then you could really be wiggling the maxilla. You
Yeah,
know, like,
I think that is something that I think would differ from a lot of people. That's something, audience, please email us because I really I would almost say elastics are my exception now. Whereas when I trained, we put it on everybody.
yeah,
You leave the OR with elastics on. And really the only times I do them in traditional jaw surgery, just orthognathic surgery anymore, is mostly asymmetry cases. Um, like I feel I've changed the bones, but you've got muscle and soft tissue and years, if not decades, of history of your face being oriented a certain way. And I feel like there is some pull back towards the norm. And so then I typically will run some elastics, but otherwise I don't really put them on until I see an occlusal problem, almost like you're saying, like if I'm like, huh, this seems like it might be shifting, or I do need to help intrude a premolar, a trick that you've showed me over the years. Like that's when I do it. Otherwise, I'm hesitant to put them on. I really don't do it anymore.
sure. Yeah, I mean, I think keeping open mind because this is definitely I don't and I think you kind of tell by us talking about it. This isn't like a set in stone absolute type kind of topic. I think when I read about it, it's very much like people who have diabetes getting on unions, but so few of my patients have diabetes. Like real life, it's like, like what we're talking about. Um, I saw a novel non-union management in the mandible within the last couple of years. I don't know if I told you about this. They had a non-union. This is another patient. I didn't participate other than taking the hardware out, but it was a proximal segment that rotated up, opened by non-union on a sagittal osteotomy, and it was managed with a crib recon plate at the
Oh
angle
yeah, you did share this with
to
me.
graft it. And it was I don't know. I actually didn't hate it. It was a whole different philosophy of treating it. Cause I mean, the crib plate, which remade the angle, was filled with bone graft, hip graft, and the crib itself served as an external fixator or a recon plate, right? Like it held the proximal distal segment while the bone graft healed. And ultimately it healed. It was just kind of like a different take. So
It's
I
aggressive.
thought I don't know. I didn't think it was bad. It was just like the thought honestly wouldn't have popped in my head to manage non-union in that way. So I thought it
Me
was an
either.
interesting one in terms of it. And then
So
maxillary non-union. So maxillary, um, I think those are hard. I think those are hard. Um, you you've managed a handful of those. Those have been the ones
yeah,
you've seen.
I got another one coming up. Um, yeah, I mean, I don't love it. I mean, even like just trying to down fracture it again and mobilize it when one segment's not solid is unnerving a little bit. Um,
Yeah, I
it's not
mean,
my
I
favorite.
think because a lot of times it's bad bone, right? Like it's just
Yeah,
hard. And so, in terms of circling around on the screw stuff, I generally think screws fail more frequently than the plates fail. I mean, occasionally you see plates break, but most of the time you see those screws wiggle out and the bone just shift backwards or shift to the side. Um, and so at least in the mid-face stuff, we're not sponsored by anyone. But Stryker has the tightest pitch screws. So like the threads are the closest together, which I think has meaning in thin bone. And I think in terms of getting as solid fixation as you can. I kind of want to do everything I can to do that. The other thing I've been using is just being sure to irrigate, tightening screws, arguably over tightening them, but a lot of the screwdrivers, like strikers like this, KLS and Synthes, at least the kits that I've used from those guys, the screws that pick up the screwdrivers that pick up the screws, they have that little nipple on the end of them. Like you can't tighten screws down always as completely as a screwdriver if you don't have the little nipple thing on it. Sorry to use that word. It's kind of I want a different word there.
Dimple? You want to do, well, dimple is,
Simple. It's a
dimple's the opposite.
anyway,
So
it's
never mind.
every time it's just uncomfortable.
Yeah.
Anyway, but there's just formal like, cruciform screwdrivers, like tightening screwdrivers. And I found that to be a great trick when I was using KLS to just tighten it. They have this black screwdriver that's helpful. And Synthes was very much the same. To where you can get like another half, three-quarter screw turn.
Are you using hand drivers or using power drivers?
Just use my hand. So you using power?
Oh man, I use power and then I go in and retighten them by hand at the end.
Yeah. All right. Either way. But yeah, Maxillas, I'm definitely bone grafting. I got a crazy one on Maxillas for you. What do you think about timing of non-union in relation to the calendar year?
You brought this up to me the other day off air. And so um, what I would say is I hadn't given it any thought. I didn't have any correlation. I know where you are, there's just zero vitamin D, eight,
It's a
9 months of the
beautiful day
year.
here today, but it's like,
It's raining here today. It's like ass backwards.
you shouldn't live in Arizona. But yeah, here, I mean, you can get some sun in the summer, but it is dark. And there's a lot of places that are more north than here. So, I mean,
Not really.
Alberta,
Oh,
all of
I thought you meant in the US.
England, Anchorage, I gotta believe because I have this at least clinical suspicion that people with non-unions, it's a higher rate if you're healing over the dark seasons around here. And I'm not sure if that's anxiety related or, just kind of like bone metabolism related.
Well, didn't you supplement them?
I mean, I give people that advice. In terms of specific dosing, I don't do that. I just, if people ask what can I do to be healthy going into surgery, some vitamin D supplementation is nice. It's just I'm not sure how much that impacts. But yeah, that's another one I'd be interested to hear on people's suspicion. But in my world, it just seems like people show up in the springtime with non-unions. So
Huh.
I don't know.
Well, what else? I mean, I guess maybe just as we have to wrap this up, um, we talked about, the classical smokers, diabetics, older people maybe more prone to it. And then I think what larger moves, right? We kind of
Crazy
hinted at that.
movements, older people, I think big jaw muscles, maybe compliance difficulties or struggles.
Structures,
Yeah. Um,
plastics, not using two screws in the mandible, things like that. Well, yeah, just for those who are watching, and again, you can watch this on Spotify. We do have a YouTube channel. I put up one of my cases that was a non-union just for a visual here. And so Sam, this is an otherwise healthy 30-ish something male. So would you look at this and would this be one of those that's on your radar for non-union?
I don't know. I mean, if the maxilla seemed unusually thin, but it doesn't scream non-union, looking at what I'm seeing here, I think I'd like to see the cone beam and that sort of thing.
Yeah.
But it
I mean, it wouldn't have been on mine except for the width change here. And this wasn't what it ended up being. This was just one visual I have with communication with the
it's
orthodontist. I
aggressive
did not.
interdental spacing.
Yeah, I didn't. Yeah, that part went away. This was kind of that we did not do that. But it was, I would say in the neighborhood of 13, 14, 15 millimeter expansion posteriorly. And so
Yeah.
it was on my radar. It got grafted and it seemed to do well and then showed up. Actually, a patient sends us a video of, hey, I'm chewing and this piece is moving.
Yeah, that seems to be this thing now, right? Like I feel like I've seen a couple of those now where people have got cell phone video or I don't know, orthodontist says cell phone video of the maxilla wiggling. Um, Man, I mean, it's cool. I think
It's helpful,
it's
right? Like,
yeah,
because
easy to
you and I and
diagnose at that
others,
point.
we see patients from other places, and sometimes if you're across the country and I see that, it's definitely Huh. Okay. Well, now I know what's going on.
Yeah, so but in this situation, I bet you it was tough. And one of the things that stresses me out in the maxillary non-union when it's a segmental case is kind of dissecting that out, right? Like
Yeah.
dissecting the nasal floor and not getting into the roof of the mouth. And then freshening up a new gap for graft to live, right? Because I'm going with the assumption you grafted that before.
Yep.
And, other than changing the type of graft, that's kind of where hip comes really starts to shine is because you can put um
I just
pretty solid
used
strips
little,
in the floor of the nose.
yeah, I just did some solid strips and putty and it worked fine second
Yeah,
time. Because let me throw this concept at you. I know a lot of us have that kind of, I don't want to say knee jerk reaction because that makes it sound like it's a bad idea, but you have the idea of, okay, what I did the first time didn't work. I've got to do something different the second time, which fundamentally, makes sense. But I would throw this concept at you when it's maybe due to an aggressive expansion and you've already kind of loosened it. Like the expansion itself is you're not expanding as great the second time because you've already kind of done it and yeah, it failed, but like you're not fighting all the forces that be that you were the first
sure.
time.
Yeah, I mean, what you're speaking to is the argument of like distraction, like the idea of doing distraction on really big movements. The argument against that is to do distraction of a big maxillary movement, whether that's in the transverse or AP planes, is that you need to do the one surgery to put the distractor in and the second surgery to take it out. And then oftentimes it's a little shy of what you want. And when you're taking out the hardware, you're kind of repositioning the maxilla at that anyway, versus just trying your best at moving the maxilla. And then, if you don't quite get that or you run into healing trouble, then you're doing a second surgery. You know what I mean? So like it is you're pushing the limit of, if you're like a 13 or a 15 millimeter maxillary advancement, or like your case here, 15 in the transverse is a lot. And if you choose Sarpy, you're still going to put them through a second LaFort because they need to move AP. And I don't know. I'm on the camp of as long as the patient understands that having a second surgery is still in the cards with these bigger movements, just because it's a more difficult thing to heal. Um, but it may be second surgery is better than a guaranteed second surgery, maybe third surgery.
I know you would think of this, but again, we do try to educate our massive audience a little bit. In hindsight, this is one that I would have considered narrowing the mandible. Like, if I could go back in time, I'm already doing the sag, I'm already doing the chin. Like, I don't have to make any different incisions. I would have maybe done, 10, 11, 12 or less in the maxilla and maybe narrowed the mandible a little
Yeah, I
bit.
mean, I like narrowing mandibles, but if the X-rays that I'm looking at look are accurate, just there's some periodontal issues in the anterior mandible. I think you're setting a guy back in the mandible, narrowing it, just minimal narrowing, right? Like there's some other troubles that could be afoot, but definitely limiting the transverse by managing the mandible is
Is an option.
you're speaking my language. Yeah, I like that a lot.
It gets a little complex when you've got chin and midline,
Definitely. Yeah.
you're getting into some things where maybe you're avoiding it in the maxilla and creating it in the mandible somewhere. So,
Yeah.
all right. Well, do you think we've done enough on this topic? Do you think
I
we need
mean,
to
I
do a
think
part
so.
two?
I feel like there's at least a few nuggets you can get into. Maybe if someone runs into a non-union, they pull this up to listen to it. Hopefully they have a couple little things to learn from. I mean, um, the reality is though that you'll see non-unions and you gotta you gotta manage them, right? And I think shying away from it and hoping it's gonna heal. Um, there comes a time where you have to intervene here. And so I think if anyone else has some tips, let us know. But I think we talked generally about the high level
Yeah, I mean,
stuff.
I agree with you. We all want all our results to be good, all our patients to be as happy as a pig in slop, but
There it
sometimes those
is.
pigs can't have their slop.
I don't
And
think I've ever seen a pig in slop, but it does sound nice.
dude, it's the best. Pigs, those pigs are so happy. If you ever want to see an animal in just genuine joy, go see a pig in slop.
Yeah, I don't know where that is in the Seattle metro. I'll keep an eye out for it though.
Don't miss your opportunity. Thumbs up. You only get one shot, one opportunity.
Yeah.
All right. Well,
Uh,
again, another Downfresh podcast, downfreshpodcast at gmail.com. This is a topic I think it would be valuable to hear from others. So feel free to weigh in. Again, feel free to send cases, topics, suggestions. We've had a few that we are going to do at some point. So we do listen. And hopefully that was useful. And Sam, I'll see you next time.
next week. All right, man.
All right. See
Have a
ya.
good rest of the week.